Samir sir is joining after 9 o'clock, sir. Ma'am? Neena ma'am?
Yeah, he should join now. I've told him he can leave by 9:15
9.
because he'll join now in probably 5-10 minutes. He will join.
Okay.
He should be there.
Sir, Kalatkar sir
Yeah.
has joined.
No, just 2 minutes. Sir. I'll just ask him because I have sent the message and called him. He said 3 minutes he'll join. I
Okay.
think just wait for 2 minutes. I think the Navi Mumbai is hotter than Delhi and I think Pune now. Yeah, Pune is the highest, ma'am.
There was a bit of rain in Pune, so.
Yeah. So आपले पापड वगैरे आपल्या तिकडे पाठवायला पाहिजे आपल्याला. भाजून
पुढे
येतील आपण.
सांगितलं पाऊस पडला 5 मिनिटं पडला.
अगर काय जे काय पडला तो that was such a relief to even hear that it's raining somewhere.
It's raining in Nagpur, so Dr. Khaldatkar must be in the rains for the last week.
Nagpur had lot of heavy rain actually.
हो ना सर.
Yeah, sir has joined.
पाऊस खूप पडला ना.
Kalatkar sir, welcome.
Thank you.
Good evening, sir.
Yeah.
Good evening, sir.
Good evening, sir.
Tremendous work you are doing, huh? What's your
नागपूरचं वेदर अपडेट पाहिजे आम्हाला.
Yes.
नागपूरला पाऊस पडतोय आम्ही म्हंटल आणि तुम्ही आला प्रकट झालात बघा.
जंगल बंद होतंय.
So somebody says Hyderabad is also very hot. So okay, everybody is sweltering in the heat then.
But first time we are facing so much heat in Navi Mumbai.
And in April.
Yeah, but we are still very cool people.
No, we are cool people, but our children are like they are suffering. No, like 3 o'clock जब आते हैं ना तो उनका चेहरा ऐसा हो जाता है कि बाप रे मंजुलिका जैसे हो जाते हैं मंजुलिका.
नागपुर में लेके आओ कुछ दिनों के लिए. तो सब हो जाएगी उनको.
चल मंगई.
Yeah, let's start. 8:30 now.
Yeah.
So we can start?
Yeah.
Yes.
8:30.
A very good evening, everyone. On behalf of Navi Mumbai IAP and the IAP chapter of Neurodevelopmental Pediatrics, I welcome you all to this very important webinar. We all know that the month of April is dedicated to spreading awareness about autism. Navi Mumbai has already conducted, not only Navi Mumbai, in fact, we are really happy to see all the branches all over conducted so many activities for spreading this awareness. In tune with this, today we have a very useful discussion, a clinically important webinar on autism spectrum disorder, navigating autism. And to help us navigate this disorder, we are really honored to have with us the best neurodevelopmental pediatricians from all across India. Before we go on with their enriching talks, let me invite our Navi Mumbai IAP President, Dr. Satish Sahani, to say a few words. Dr. Satish, sir, please.
Good evening, all. I think it's our pleasure to have immense and eminent faculty from all over the India on Navi Mumbai IAP dais. And this gives like a lot of pleasure because the benefit out of this content and webinar is percolated over a time, and this is a YouTube live. So over a time, the people will again and again see this webinar. So I really thank my team, especially Dr. Vikram and Dr. Shweta, who has taken pain to conduct this all content of the webinar, and definitely Dr. Lina Deshpande as a backbone of IAP Navi Mumbai, as a I would say main supporter because she never says no to anything. She just say kaitari karuya, something we just find out the way to do that, and she has done wonderful job. I witnessed that journey because I practice in the same area where the madam practices. So I can, so we can, and we can. So definitely I welcome on behalf of Navi Mumbai IAP to the all faculties, moderator, chief guest, Dr. Vasan sir, and Dr. Shiva Prakash sir, Dr. Central IIPAB, Dr. Jitendra Gawane sir, and many scholars here. So, Jitu sir, please carry on. Thank you, sir.
Yes. Good evening, everyone. On behalf of IIP Navi Mumbai, I welcome you on all on this Zoom platform. Respected Dr. Khalatkar sir, President Central IIP 2025. Uh, Dr. Leena Srivastava ma'am, Chairperson, Neurodevelopmental Chapter of IIP. Dr. Shambhavi ma'am, Secretary General of Neurodevelopmental Chapter. And respected all senior colleagues, Dr. Shiva Prakasham sir. I'm very happy to see all the great people at common platform discussing about every aspect of autism today. And as our beloved president, Dr. G.V. Basavaraj has told us to take all the important days to the community, like with IIP Ki Baat community ke saath. So this year we have celebrated World Autism Week or month, we will say, with a new zeal under the guidance of Leena Deshpande ma'am and Shweta ma'am. Here in Navi Mumbai, all the developmental pediatricians have a cohesive bond and they gel well and do same type of practice, and that becomes easy for us pediatricians to follow their advice. So I welcome Dr. Vasant Khalatkar sir here. Dr. Vasant Khalatkar sir doesn't require any introduction. He's Yaro ka Yar, and is going to lead IIP with a big way, and he has very great plans, and one of the plan is for neurodevelopmental chapter also. I'm not going to reveal that anything, and many things are in his basket which he will unveil at Hyderabad Pedicon only. So, respected Khalatkar sir, I request you to say few words. Thank you.
Good evening, all. First, I want to congratulate Navi Mumbai branch and Neurodevelopment chapter. Actually, neurology is by heart to me, but very close to me. You know everything. How I work in neurology and along with Neurodevelopment chapter. I never differentiated this chapter. There's neurology and neurodevelopment because they always go hand in hand. So I welcome you. I thank you for inviting me. Today I saw there are two Lina. When there are two Lina, then there are twin. इधर एक से दो भले बोलते तो हाथ में हाथ मिला जाए तो सवाल ही नहीं. This is going to be hit topic today, and definitely Satish, Jitu, they are working hard, and Dr. Sambhavi. So everyone is from Navi Mumbai. Okay. Dr. Mangai, and I saw Samir is there. The boss is there. So
yes, boss joined. Huh?
Boss joined.
Namaskar, sir. Namaskar.
Yes. So Shweta and all, I saw the initiative beginning 73 participants. So definitely this is the topic of interest. And everybody now, because of this IIP ke baad community ke saath, everybody is working hard to reach the community. And I know Navi Mumbai is always in forefront for such project. And the only my worry for this, the message should go to community that they should not go to back. Because we have taken a lot of efforts, a lot of pain to develop this neurodevelopmental pediatrician. You see, it's a out of range. Somebody is doing this neurodevelopmental specialty. That's really out of box. My message should be, our message should be that to community, you should go to your concerned doctor, not to quack. And that is the really worry something that people are going to different paths. So they really, it's very difficult to manage such thing, and our message should be very straightforward that they should go to either pediatrician and neurologist and neurodevelopmental therapist. We have to form a team that we know we are doing, but we should be very conscious and do the teamwork. It's always teamwork. So then only everything is possible. And as per Jitu said, next year I'm definitely having good plan for neurodevelopment chapter, but it's not me. in IIP. It's all you people who are going to suggest me. मैं तो आप लोगों का एक सेवक हूँ कि I will propagate.
प्रधान सेवक सर.
Yeah. So definitely, whatsoever you will suggest, I will do the best, and I hope this chapter will do the best under leadership of all you enthusiastic people. I saw that Dr. Siva Prakashan also. See, really, he is also doing the great work in this. Yeah. So I wish again all the best, and this autism topic should reach to community and they should get built in. Let us hope for the good child health who are the future. Thank you.
Thank you very much.
Thank you
sir.
so much, sir. Thank you,
Please
sir.
welcome Samir sir.
Samir sir, welcome. Welcome to the webinar. So we would like to just hear a few words before we start with the scientific session, sir.
No, Namaskar, respected President sir, Dr. Khalatkar, respected Jitendra Gamane sir, respected Shivakasham sir, respected Leena Srivastav, chapter chairperson, respected all the office bearers of Navi Mumbai Academy of Pediatrics, respected all co-faculty, all my other friends. I am a host and not the guest, as I am from Navi Mumbai. So I will just say thank you so much and let's go on with it. Thank you so much.
Yeah, part of the family.
Absolutely. Thank you. Satish, thanks.
We now begin with the scientific session, and who better to conduct and moderate this session than our own young neurodevelopmental pediatrician from Navi Mumbai, Dr. Shweta Nair. Dr. Shweta Nair, I would really want to mention that I just told her to think of ideas to celebrate this Autism Awareness Day and week and month. And she, with under Leena ma'am's guidance and the entire team of neurodevelopmental pediatricians in Navi Mumbai, just like Sir said, that it's a teamwork. So they all came up with such interesting activities for this. So thank you, Shweta, for that. And Shweta practices at Khushi Child Developmental Center in Seawoods and Panvel, and also is attached to Apollo Hospital. She's done wonderful work in conducting all the activities for Navi Mumbai and even for this webinar. So over to you, Shweta, for moderating this session.
Thank you, ma'am. Thank you so much. So good evening to all. I'd also like to welcome all of you to this Autism Awareness webinar conducted by NMAP and the IAP Neurodevelopmental Chapter. Despite conducting so many awareness programs, including talks, CMEs, webinars, campaigns, has the incidence come down? Can it be reduced? Or it rather be easily identified by more medical professionals by these measures so as to seek early and proper intervention for all the children and help their families or caregivers? We hope to get closer to the awareness, acceptance, and ameliorate their living standards and incorporate them into inclusivity by today's session as well. So, on that note, let's begin navigating autism and debunking the myths associated with it. We'd like to begin today's webinar on an auspicious note with the Saraswati Vandana.
या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः रामा पातु सरस्वती भगवती निःशेषजाड्यापहा या ब्रह्मविचारसारपरमा आर्याव्यापिनीं वीणा पुस्तकधारिणीम् अभयदाम् जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधति पद्मासने संस्थिताम् वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदा
All right. So the first speaker for today is Dr. Sameer Dalwai. Sir is a developmental and behavioral pediatrician, and he's a recipient of the Rajiv Gandhi Manav Seva Award for 2012 for service to children by the Government of India. He has been a co-chair of the IPA subcommittee on ECD. He has also been the national treasurer for the year 2022-23 for IAP and joint secretary for the year 2020 and 2021. Sir is the founder director of New Horizon Child Development Center and Research Foundation and is an editor-in-chief for the IAP Handbook of Developmental and Behavioral Pediatrics. Sir has also published various consensus statements on all possible conditions in our neurodevelopmental pediatrics and is a trustee of the Yashwantrao Chavan Pratishthan, Mumbai and Dalwai Education Trust. Sir has been the chairperson of the IAP chapter of neurodevelopmental pediatrics from the year 2014 to 17 and president of the IAP between 2016 to 17. He's also proposed the New Horizons theory of human engagement and intervention for autism and New Horizons social behavior and communication sequence. Sir will be speaking on the evolution of symptoms of autism. I request you all to please put your questions in the chat box and also to all those who aren't speaking currently to please mute your speakers. Thank you. Sir, over to you.
Yeah, so thank you, Dr. Shweta, for your kind introduction. Dr. Khaladkar again, Dr. Amol, my friend, Dr. Jitu, dear Satish Ji, dear Dr. Manga Sinha ma'am, all my co-faculty, Dr. Leena Srivastava, Dr. Leena Deshpande, Dr. Shambhavi Seth, Dr. Rupa Srinivasan, as well as all my other friends from the chapter, as well as Navi Mumbai Academy of Pediatrics. Thank you so much for this wonderful opportunity, and I will take your permission to begin with the presentation. Is it visible now?
Yes, sir.
Yes, sir. Yes, sir.
So thank you so much again, everybody, all the office bearers. And we are going to speak about, I think I really like the entire theme of the seminar that we have looked at, which is navigating autism. The evolution of autism symptoms is what I'm going to be speaking about. And I think it's very important to put that in focus right away. Why is it important to focus on evolution of symptoms of autism today? Just give me 1 minute. Beg your pardon, sorry, there was some problem with my charger. So the whole point is, why is it important to focus on evolution of symptoms in autism? As we know today, when we look at the entire story, and as our friends mentioned, that in spite of so much of incidence of autism, in spite of so much of awareness work we are doing, is there any change? I'm also going to bring in another point. In spite of so much interventions also, is there going to be a change? Because what we are seeing now is, currently there is no known etiology and hence no known definitive cure for autism. And there is no global consensus on which intervention is most effective. Hence, it is still what is called as an enigma or a mystery for many, many people. And hence the interventions, not surprisingly, is largely symptomatic. Whatever symptoms the parents face, they still believe, and everybody else also believes, in referring them for a solution to that symptom. Now let's look at the picture from a different point of view. We have a total population of 1.4 billion people. Below 18 is 500 million people, children and adolescents, and 25 million children are born each year. If you look at what they are saying is the worldwide incidence of autism between 2 to 3%. If you look at that in terms of numbers, can you believe what the numbers are in India? The children and adolescents below 18 years, if you look at them, there are probably 15 million children with autism and counting. And if you look at the entire population, there's about 40 to 42 million people on the spectrum in our country. Just to put that into contrast, if you look at it, Australia, the entire continent, has a population of 26 million, whereas UK has a overall population of 67 million. This is the number of people in India here, as you can see in the blue here, with on the spectrum just in our country, probably twice the number of the entire population of Australia. And hence my question is, can we let such an important burning issue remain an enigma or a mystery in our country? And this is what always stuns me into silence. How is it that we have allowing ourselves 81 years after what Canner described in this first paper, that we are still happy to say that this is an enigma and this is a mystery, and how we are not taken up by the fact that we need to find out more about this. And what do we see? What is it that we still talk about autism? We largely talk about symptoms, and then what do? We do symptomatic therapies. So if you have see issues, a child does not speak, do something, it prefers to be alone, another therapy, doesn't interpret what others feel, another therapy, repetitive movement, some therapy, maybe whatever XYZ. I don't want to name anything, avoiding eye contact, something else, sensitive to certain noises, of something else, and so on and so forth. We have an entire gamut. And hence, the poor pediatrician whom we have been laboring after for the last 10, 12 years through Indian Academy of Pediatrics, now is aware that there are so many options for referrals. But his question is, what happens after that? When the parent asks me, can my child never become normal? I know there is a big issue about this word normal, which we'll come to later, but that's exactly what every parent wants to know. And hence that brings me to this fact that there are two Indias that we currently live in. One is the large population which has poor accessibility towards any healthcare, and hence they are not even aware of what is a speech delay, much less what is autism. There is, even if they are aware, there is no question of any services provided to them. There is lack of drinking water in large parts of the country. So ये services कहाँ से मिलेगा? And of course, huge distances and very difficult issues of traveling and cost of traveling. But there is still, can you please mute everybody, host? Yeah. Still, there is relatively better accessibility to a large population of India now, because now India is on the move. We are growing and we are being taken note of by the whole world. And hence, there is an increased awareness. Look at what the IIP, look at what Navi Mumbai Academy, IIP Mumbai, look at each and every branch in the country. Look at how many events. I think Lina, all of us have to just count how many workshops we have spoken in just in the last 10 days, 15 days. It must be humongous. At the same time, we have created awareness, and what has that led to? A large number of children are now under the medication or therapies. We did a study in 2016 or 15, 16, and we saw that children being referred to any center, or our centers at least, were after age of 6.5 years. That was the average age of referrals. Today, all of us are seeing children even around 2 years of age. So the number of children availing medication, therapies, and complementary therapy, and we know of a great example locally, if it's a predatory therapy, I would call, is increasing. Yet, what are the problems? They are very, very expensive. But the problem is beyond that. Even if it is given free or at subsidized rate, what is happening? There is no robust licensing. There is no documentation of what is being given. Children come to us for second opinion, sometimes after 4 or 5 years of intervention, without a scrap of paper saying what was done to them. No monitoring, no regulation by any authorities or any self-regulation, and no robust about what's happening in India currently when such a large population is undergoing therapies and interventions and medications year after year. And hence, the reason that we are seeing it today is there are limited outcomes with current interventions in most cases. So surely some children do well, some children are able to do everything. But globally, we know that there are limited outcomes. Speech, we do see an improvement after intervention, but we are not sure largely whether it is echolalia or normal, meaningful, purposeful speech. Academic, everybody wants their child to be in school now. So now the schools themselves have set up these therapy rooms where parents have to pay almost double the fees only for this. In spite of that, the child doesn't do better. So now they have to have a. So now we have to have a shadow teacher for the child to go into the school, paying another 18, 24,000 per month. And one day, if the shadow teacher is absent, the child is sent back from the gate. So what did we achieve by doing whatever we have? And we are very clear that when these children go towards adolescence, what parents get troubled by is poor social behavior and poor integration in society. And there is this huge dependence on caregivers or patterns of care, and that pattern largely now resides around screens. So the question is, are we setting the right goals? And are we even identifying the problem of autism correctly? And this is perhaps the reason what is seen, because we are looking at the symptoms but not looking at the root causes. And that's why we need a new perspective to address the root cause that leads to targeted effective treatment. But the way to get there is by finding out what causes these symptoms in autism, rather than just making a chart and a list of all the symptoms and then referring to early intervention, a term which is shrouded in mystery, as enigmatic and as mysterious as our understanding of autism. तो भेज तो रहे हम अर्ली, लेकिन वो अर्ली भेजने के बाद लेट तक होता क्या है वो हमको नहीं पता. What is the opportunity that we have here? Is there a better way of explaining the symptoms and the etiopathogenesis? How is it that we are getting these symptoms? And why is that important? Because if we are able to do that, only then can the intervention move away from symptomatic interventions to more definitive intervention. And then possibly, can we set different or more practical goals from the social interaction and the social behavior perspective, and able to get these children to integrate in society? Now, what I am going to present after this is a point of view of one individual or one organization. Why am I doing that? That may not be the right thing. That may not be the perfect thing. But the idea is, if one organization or one individual or two can do it, three can do it, then everyone can do it. And that is very important now, to raise this thought that let us not stop at saying these are the symptoms. We refer to early interventions. At the end of the day, some get better, most of them don't get better. At that time, we'll put up our hands and say, oh, this is autism. We knew it never gets better. And now there is a new thing. Oh, they were never going to get better. Let's accept them as the way they were. Try telling that to the mother of a 2-year-old child that this is neurodiverse, accept your child as is. Let's see what she tells you when she comes to you for the first time with a 2.5, 3-year-old child and you tell her all this. I don't think she's going to be mighty pleased. And hence, what my point is, all of us who are working on autism need to go beyond this conundrum of these are the symptoms. Then we do a DSM-5 diagnosis, which is nothing but a scoring of the symptoms. And after that, what do we anyway do? Refer for symptomatic therapies. And when things go well, good. If they don't go well, we say that, well, that's autism, what can be done? One way of looking at it is what I'm saying. And I hope this provokes everybody else into coming up with their own point of view. And at the end of the day, if 100 of us come up with our own point of view, I'm sure thousands of children will benefit. What we looked at is generally the symptoms belong to these 5 common areas: human engagement, daily behaviors at home, neighborhood, society, and school; non-verbal communication, joint attention, pointing, gestures; verbal communication, speech, and reading and writing, which is academics. After having looked at a large and huge number of children under intervention over years and years and years, and having the privilege of being able to follow up them year after year, what we came up with is basically what is the problem with autism is it's a condition where the child fails to connect, interact, engage meaningfully with humans, and instead more drawn towards objects. And this is something since birth. So this probably definitely a genetic condition which probably makes the child drawn more towards objects and does not connect, engage, interact meaningfully with humans. And this is, like we said, since birth. Then we went on to propose the milestones of behavior and communication domain, or social behavior and communication developmental sequence, where we believe after birth it is the human engagement that the child normally has that leads the child to pay more attention to people around the child, obviously the parents and the family members, and that makes the child understand daily behaviors more. All of this is driven in by neuroplasticity, where the child's brain is now getting more and more developed via neuroplasticity towards human behaviors, to the point by the time he's 8-9 months old, he's able to understand non-verbal communication like waving or gestures or pointing, which he or she was not able to understand at 2 months because the brain wasn't developed enough along the way to reach this. And that's why it takes a good 8-9 months of good human engagement, good learning of social behaviors, to be able to even get to the point of communication, which is initially non-verbal. A good 3-4 months of good non-verbal communication makes the child understand verbal communication, that is speech, And only after you develop that for a good couple of years are you able to understand reading and writing and academics. So perhaps like sitting, standing, walking, running, and jumping, these are steps in the sequence that need to be achieved by the child for driven by neuroplasticity that helps the child achieve all these normal developments. What can be proposed is that if there is a problem with the first step itself, even if there is just one problem that the human engagement part of this child is poor, can we explain the symptoms coming out of this entire issue? Yes, because if the child lacks human engagement, you will obviously get poor eye contact. You will not get any response to name call, which are two very common signs of autism. If the child doesn't develop human engagement, he won't go to the next step of learning normal social behaviors or daily behaviors. And hence the child won't know what to do when. How do we behave in certain situations and how do we behave in others? So you'll see this child running around all the time for objects, which you may think is what we call hyperactive behavior. He obviously will have no pointing, he will not understand gestures, and that's why he will not go on to develop verbal communication, which is why you will get the receptive speech delay where the child does not follow commands which are told. And obviously, thereafter, the child will not have developed expressive speech, and hence there is an expressive speech delay. So these are the cause of all the symptoms, is what we were able to understand. And the other story is even more sinister because he's not focusing on objects, on humans, he ends up focusing more on objects. Now, each object is arranged or runs in a pattern. And hence, this child becomes a pattern ustad. It's becoming a master at copying patterns, but these are not understood human wise or the way humans use or understand these things. And hence, they end up being rigid or stereotypical behaviors, does the same thing everywhere purposelessly. And this is where we get the echolalia from and restricted repetitive behaviors. And the largest number of symptoms that come out in the child are not from the absence of human engagement and development, but rather from this object orientation and pattern learning. Because all that we then start doing when we directly start with speech and we directly start with teaching the child nursery rhymes and actions and copying this and copying that, the child may end up copying it, but as a pattern, not knowing when humans do it and when humans do not do it. And hence, this is where we realize that most of the symptoms of autism come from. So what we are proposing is basically the problem is not with speech or reading and writing or school. The problem is in the child's innate interaction with humans. If the child's innate potential of interaction with humans at birth is normal, she will go on to develop normal social behavior and communication. But if it is deficient at birth itself, the child will develop impaired social behavior, go on to develop impaired nonverbal and verbal communication, and excessive focus on objects will lead to pattern copying. And that's where we get this impaired social behavior and communication and restricted repetitive behaviors, which is what DSM-5 defines autism to be. What we are trying to say is, ये definition तो ठीक है, लेकिन यहाँ तक बच्चा पहुंचा कैसे, इधर आया कैसे इधर तक? How did he develop poor speech, restricted behaviors, repetitive behaviors, echolalia? And I think, dear friends, that is very important to understand that there is a pathway which leads to normal social behavior and communication. And perhaps there is a pathway which leads as a road or develops to autism spectrum disorders. Why is this important? Before we come to that, let's look at one more thing. How do we currently diagnose these children? Whether it is DSM-5 or ICD-10, this is nothing but a scoring of the symptoms. If you have 9 out of 10, you have a condition diagnosis or you don't. For example, in ADHD, you have 6 out of 9 in each of those situations, and this is done after a certain age or before a certain age. And if it is done at multiple places, what is all this? This is scoring of symptoms. Fine, fair enough. Why do we need it? Because we need some standardization for research, I understand. But please, my medical friends, remember, this is not a diagnosis set in stone like what we assume. So when somebody comes back to you with a 50-page report, which you have no time to see, which I also have no time to see, but it shows diagnosed as autism, please understand, this is just a scoring of the symptoms. It is not set in stone. And even the report will say a high probability of having autism, because this is just a scoring of the symptoms. It is not like peripheral smear for malarial parasite seen. Malarial parasite seen in the peripheral smear, or it is not like a blood culture that has grown salmonella, or it is not like a tissue biopsy of a malignancy. So please keep this in mind before we label the child forever. And what is the advantage of doing this? If you are able to understand the etiopathogenesis of how this symptom develops, the first issue itself was the failure of the beginning of the normal sequence. And hence, if we are able to shift the entire scope or the entire focus of intervention away from symptomatic therapy towards a targeted sequence-oriented intervention using so many principles of nurturing care and early childhood development, then the child will start progressing along this sequence towards normal development and normal behavior. What are the goals we should set? We should set the goals as human engagement, social interaction, and independence rather than shape sorting, puzzle solving, solving those puzzles, 150-piece puzzle, 100-piece puzzle, or rote speech, mama bolo, good morning, where the child will end up saying good morning, evening, afternoon, night also, if at all he does say it. And then if you ask why is he saying good night, good morning even at night? It's autism. Itna to baat kar raha hai. He was not saying anything at all. Now at least he's speaking. Or writing ABCD 1, 2, 3, 4, add nauseum. But never knowing when to write, when not to write, when to speak, when not to speak. And not knowing how to behave with chachi, bua, masi, kaki, which is far more important than reciting Shakespeare without understanding any word of it. And hence, coaching parents has become far more important than any pressure points in the child or sensory issues in the child, for which we have been doing it for so many years. And once we understand that coaching parents is far more important, this can even be delivered online. So there has to be some evidence for what we all do. So obviously this is a new method. This is a little effort from our side to get it published and to get it into peer-reviewed thing. And this is a story about two children whom we have not even seen because they're out of India, who are given this kind of intervention and coaching for the parents without any therapy for the child, not even touching the child, where over a period of 5 to 6 months, what we know that haircut experiences or nail cutting are very shocking and horrifying and terrifying instances for children, just by coaching the parents to work according to the sequence. First work on human engagement, then work on understanding social behaviors, and then taking the child in a particular way. The child is now able to get the haircut or get his nail cuts or do everything else, or go in a crowd, go to a mela, for example, without any of the problems that we see with children with autism. And hence, I'd like to close by some key messages that I'm going to suggest. That we all know that the challenges are humongous in our country in terms of numbers needing help, as well as the scope for malpractice, perhaps unintended. Nobody intends to do anything wrong, but that's what we've been taught, that if this is what it is, do this, because ultimately you can never make the child completely all right. Who told us to believe that? And that's why increased service delivery of symptomatic therapy cannot be at the cost of the outcome for the child. Is this child able to survive without the mother? If not, I don't think that's the right outcome that we should be looking at. So what may work in the Western countries perhaps may not work in our country. And we need more local innovation and research focusing on outcomes for our Indian population, our Indian situation, our social situation, our economic situation, rather than replicating the programs at low cost that may be suitable maybe in the United States. Just because we are able to provide it at low cost doesn't mean that this is the outcome that we wanted in the first place. So please give that a thought. And we cannot sign off or give up yet, nor bring the gavel down on making autism a lifelong sentence for children and families. Never ever tell anybody, autism है ना इतना ही होएगा और कुछ नहीं हो सकता है. And this can be achieved by a better research by all of you, everyone, into what causes the symptoms, rather than racing to deliver symptomatic intervention in the name of early intervention. So thank you so much for giving me a patient hearing. And once more, thank you to the chapter as well as the Navi Mumbai Academy of Pediatrics for this wonderful opportunity to discuss and have a word with all of you. Thank you very much.
Thank you very much, sir, for the enlightening talk. Sir, if you don't mind a query, please.
Please go ahead.
Sir, most of the times when we ask parents, can you explain what all your child speaks or about the child's speech, the mother or the father starts by saying, my child can recite all the rhymes, count 1 to 100, identify colors, even be it burgundy or teal. But how do we explain to them what do we actually mean by meaningful speech? Or what are we actually asking about the child's level of communication? How do we ask that from the parents, sir?
By understanding the fact that there is a difference between echolalia and normal speech. And for that, I have an acronym which I made many years back, which many of you are knowing and using, which is IMP. Otherwise, it stands for important, but here it stands for interactive, meaningful, and purposeful. If I'm looking at my mother, now Shweta, imagine you're my mother, okay? And I'm your child. I'm looking at you. I need something from you, maybe a glass of water. And then I'm saying, Mama. That means I'm interactive. I know the meaning of the word mama, and I know that you also know the meaning of the word mama. Hence, I say mama. That is meaningful and purposeful. I have some work with you. That's why I'm calling out to you. I'm not just either looking at you and saying, Mama, 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 in the tone that I learned from the YouTube video or some person taught me in some therapy. And I'm not going on. And at the same time, I'm not calling everybody Mama, which is meaningless. And at the same time, I'm not looking at you and saying, Mama, can you get me water? No, I'm looking at you. I'm not looking away. So there's interaction, meaningfulness, and purposeness. This is normal communication. And absence of knowing this has made us believe that 33% children regress after being able to speak at 1 year, and then unfortunately the vaccines got the brunt of it. It has nothing to do with the 9-month MMR or measles or 15-month MMR vaccine. What they were saying earlier was in large number of cases, I won't say all, echolalia. So what we need to explain to parents is, unless the child is interacting with you, he's using that word meaningfully and he's using it purposefully, it is not normal speech. But we also need to tell them that children with autism, and that's why I explained this model, have a higher amount of pattern learning. If the child has not gone through the normal human engagement sequence, human engagement, human behavior, non-verbal and verbal, it's like not being able to sit, he's not going to be able to run. Similarly, if he's not having human engagement or eye contact, teaching him speech ad nauseum will not make him understand speech. But if you do it repeatedly, it becomes a pattern. If the child likes the pattern of say mama, he may repeat say mama, or he may repeat only mama, or he may repeat only say. If he doesn't like the pattern of say papa, he will never say papa. No fault of that poor papa. And this is what we need to explain to the parents, that speech is not what comes out of your mouth. It's not the noise or sound that comes out of your mouth. It comes from your brain. And there is a definite interactive element, a meaningful element, and a purposeful element to it to be made speech. So the true speech, I'll say that as the last word, is not what you say or not what comes out of your mouth. Correct speech is knowing when to speak and when not to speak.
Thank you for so much clarity on such a simple question, but which is asked by parents all across. So moving on to our next talk, our next speaker for the day is Dr. Leena Deshpande, ma'am. So Dr. Leena Deshpande is a developmental pediatrician in Navi Mumbai. She has 25 years of experience behind her, of which 10 years were in the United Kingdom. She's the founder of ICAN Child Development Center at Kharghar in Navi Mumbai. Ma'am is also associated with Apollo Hospital, Kokila Dhirubhai Ambani's Hospital and MGM Hospital in Navi Mumbai. She's the West Zone Coordinator for IAP Neurodevelopmental Pediatric Chapter and is the National Coordinator and Convener for various TOT of neurodevelopmental disorder. I request you all to please mute your audio in case you're in speaking right now. Ma'am is also the member of IAP Task Force for IAP National Consensus Guidelines on ADHD, Autism, Newborn Screening, and Learning Disability, and is a member of the Accreditation Committee for Institutes applying for IAP Fellowship Program in NDP. She's the academic editor of IAP Handbook of Developmental and Behavioral Pediatrics, associate editor of the Indian Journal of Developmental and Behavioral Pediatrics, and has been a faculty on various forums. Ma'am will today be speaking upon various evaluations conducted for autism. Over to you, ma'am.
All right. Thank you. Let me just share my screen.
Sure.
Yeah, you can see it?
Yes, ma'am.
Yes.
All right. Thank you, Shweta, for the introduction, and thank you, NMAP and the chapter for making me part of this webinar. As I can see, I'm some excellent and amazing company here, and it's great to be a part of this this event. So when we talk about anything in life, there is an ideal way and there is a practical way of doing things. Okay, and a lot of times we find that it is probably not practical to be ideal. So in autism, when we talk about these evaluations of autism, there are a lot many protocols which have been set by various organizations, associations, which are doing amazing work across the globe. But as Samir said, they may not be practical in our country. We have completely different setup. There are many Indias in one India, and in different kind of settings in our country, it may not be a practical thing to do. In fact, all these ideals go out of the window, even for Western countries. And let me just show you this. This is a child. This is a message I got on WhatsApp a few days ago. This is a child who was 6 years old and whom I had seen only once. This was about a year back. And the child had autism spectrum disorder and had been under various therapies for the last 2 to 3 years before they saw me for the first time. The family was shifting to Canada, and I did mention to them that the child has autism spectrum disorder. But when you go to Canada, you will need to do formal assessment. Now, they went to Canada. They decided to do the assessments in Canada. And I got this message a couple of days ago. Hi, doctor, can we do formal assessment of ASD online as the school needs that? We have tried to find a doctor here for assessment, but we are unable to get it. It's too lengthy. Else they will take educational support away. If it's possible to do online, they are okay with assessments from India as well. So as you can see, when somebody wants to help a child, all ideal protocols may go out of the window. They have to be set aside. However, we have to give a lot of thought and be very cautious before we give a final, as Samir said, a proper lifelong diagnostic label to a child. We have to give a lot of thought to that. So let us just start by, I'm just going to put some cases here. And all these are true cases. They're all that we see, and there are many, many hundreds and thousands more cases like this. Now, this first child is a 30-week gestation, 800 grammar with a stormy neonatal course. But the parents were from a rural area, so they went back after the discharge from an ICU. So there was not much of a postnatal follow-up. The pediatrician saw them directly at 4 years of age, where the pediatrician noted speech delay and poor eye contact. And as we know, was referred to a speech therapist for suspected autism at that point. The speech therapists, however, in Navi Mumbai are amazing. They referred for developmental evaluation first, and this was a while ago. And to cut a long story short, this was the vision assessment. The right eye had complete retinal detachment. The left eye had partial retinal detachment because of ROP. So this child had completely fallen through the net because of poor follow-up from the family side. But the eye contact was probably because of the vision, the poor vision. Let's come to a second child. This child is a 4-year-old who came with a diagnosis of autism, which was given by 2 different professional specialists after an consult, which happened 6 months apart. And the child underwent online OT for about a year. When they came to see me, so the parents were from another town, another city. They shifted to the father shifted to Navi Mumbai. And in clinic, what I observed whether the child had a very good social engagement and a play pattern, and there were some mild delays in communication. The father and the paternal grandparents were there who were counseled. They were started on basic communication counseling regarding age-appropriate stimulation, interaction, play, and within 3 months, this child was nearly normal. The social history in this child was very significant. What had happened was the child and the mother, through the lockdown, were with the maternal grandparents, and the maternal grandfather was suffering from cancer. He subsequently passed away. Following this, the child's mother as well succumbed to COVID. And as a result, the whole family was distraught. In this, the child was really left alone and had a very poor stimulation due to circumstances. At the same time, there was this diagnosis of ASD, which was given by an online talk. And this resulted in OT and ongoing OT and some kind of therapies online. As soon as the parents shifted, the father shifted with the child to the paternal grandparents. Both the paternal grandparents had been teachers in the past. Good stimulation, good circumstances, the child recovered very quickly. Let's come to this third case. This is a little bit more bizarre, though not uncommon at all. This is a 20-month-old child, and the pediatrician rang me up urgently to get an appointment as parents were in a panic state. And the story was the family had gone to a pilgrimage, and while waiting at a bus depot, a lady approached them and said, I have been observing your child. He's running around. He's very excited. He doesn't seem to respond to you. He has autism. I'm an occupational therapist. I can help, but you need to start online sessions ASAP for the child. So in clinic, when I saw as an urgent appointment, there were no features suggestive of autism at all. The child had mild speech and language delay. And then this fourth case, a 2-year-old, discussed the concerns with pediatrician regarding poor response, no communication by himself. The parents were very worried about autism because they had heard so much. Pediatrician rightly said, stop screen time, start play school. COVID times have been difficult. Doesn't look like autism. Now, 1 year went by, and at 3 years, the parents came back. The child was referred for assessment, and it was autism spectrum disorder. So, in short, there's a lot of misdiagnosis and missed diagnosis in autism. And why does that happen? Because as Samir rightly said, we are looking at symptoms in isolation. No eye contact is equal to autism, or very good eye contact is equal to not autism. And the same thing for response to name, hyperactivity, toe walking, echolalia, or simply looks like autism are the statements that we are throwing around. I remember about, it was 2017, I think, that the chapter started the TOTs to pick up autism early. And that was when, before that, the screening test, the autism screening test, the MChat, which we are very popularly using now, nobody knew about it. But with increasing awareness, a lot of people are using this as a screening test, and a lot of psychologists and other professionals are also using it. And now diagnostic labels are being given based on these screening tests. I think we need to understand the difference between screening, surveillance, and diagnostic evaluation, and to understand that a screening test is a screening test, and there will be a lot of false positives and false negatives. And that's one of a very common mistake that we make. When I see reports for these evaluations of autism, which have come from different sources, I find that people are using the various diagnostic tests which are available. There's a ISA, there's a CARS, but they're all ignoring the age criteria. So all these diagnostic tests are for 3 years plus, but there's a 2-year-old child who's being done, whom ISA is being applied, and the child is being diagnosed and labeled as autism spectrum disorder. And then we rely sometimes very solely on parental reports, as mentioned, over-reliance on a questionnaire rather than observations. And parents don't know. They might have read up about it. They may over-report, under-report symptoms, and you will end up getting wrong answers to the question. And then some other mistakes are, there might be insufficient knowledge of how a child's development develops. And sometimes, as Samir very rightly said, symptoms are dug up to fit the diagnosis. I have seen so many notes written in the evaluation. The child was so scared of firecracker that becomes a sensory symptom, and it is not. Okay. And then insufficient consideration, as I say, given to the boundaries of one's own action. And some people work in the belief, in the mission of taking actions for the good of the child. I think that is what that occupational therapy, I hope, was trying to do when she looked at the child and diagnosed autism at a busy bus trip. And then using terms like virtual autism. I think virtual autism this term has become ever so common in the last 2 to 3 years, and it is thrown about so often and so frequently, and parents latch onto it. Now, there is no diagnosis or medical term called virtual autism. It has been coined by somebody. There is either autism or there is no autism. So we know that autism is there, and there is a differential diagnosis of autism. Poor stimulation, maybe excessive screen time might mimic autism, but it cannot be coined as virtual autism. So all in all, the main mistake that most of us make is we are in a hurry to label a child, and hurried, incomplete evaluations will definitely cause more harm than good. As we all say, early pickup of red flags, starting the right intervention is important, but diagnostic labels neither important nor needed for interventions and can be harmful. So a slight error in the beginning results in a big mistake in the end, as they say. And what is this mistake? What is the impact of this mistake? We say when a man who's holding a hammer, everything looks like a nail to hit, and he goes hammering everywhere. So following any workshops or any awareness activities, we might end up missing a lot of correctable conditions like vision, hearing, if we think that everything which without eye contact, everything where there is no response is autism. When we give a finality of a label, very rightly, it is an extremely traumatic experience for the parents. They will go through this whole gambit of denial, anger, depression, stress, and they will go on pursuing for second opinions and third opinions till they get an opinion that they want to hear. They will pursue non-evidence-based medicine, treatment methods, social media influence, brain tonic, stem cell therapy, inappropriate interventions, unnecessary treatment, child's time, parents' money is wasted. And we do know that between 3 to 25% of children previously diagnosed with autism at some point lose the diagnosis. Now, some of it is obviously because of neuroplasticity, early intervention, but many are maybe due to diagnostic errors, which we are giving labels too early to the child. And then what is the impact of a misdiagnosis? So misdiagnosis is different and a missed diagnosis is different. A delayed or a misdiagnosis obviously has significant consequences. We all know that it is very important to have early and right intervention. So why is there so much difficulty? Why is there so much confusion about autism? Because as we say, it's a spectrum disorder. Every child does look different. And we talk about social skills, communication skills, when we talk about sensory skills, behavioral, all these, every child will have different areas of where the child is doing one better than the other. But the core problem remains the same. So that every child will have that social, the communication, that behavioral pattern and all those to the core symptom. And all these behaviors will also depend on various non-autism specific factors like IQ of the child. So a child who has autism spectrum disorder may have a normal IQ, a low IQ, high IQ. And depending on his cognition, the child is going to pick up whatever the child is being taught. If the child is being taught the right things, he will pick up the right things. If the child is being taught the wrong things, the child is going to pick up the wrong things, depending on what the child is offered in therapy forms. And then if a child has all these other associated disorders, a child with autism and ADHD will look completely different from a child with autism and verbal apraxia. And hence, it is needed to go through a thorough evaluation before we give some diagnostic label. But let us remember this, that diagnostic labels are certainly not needed for starting interventions, definitely not in India. Okay. So what are these evaluations? Yes, we determine, as was mentioned, whether the child has these symptoms of autism, how many symptoms they have. They have 9 or 10 or 15 or 50. And then quantify and qualify how these symptoms affect the child's ability in daily life. But apart from that, as you know, we have to look at what is the strong point and what is the weak point, and evaluate along with this all those factors which will interfere with whatever interventions we are going to suggest. A child who's not sleeping well is not going to follow anything. A parent who's not sleeping well with the child is not going to be able to do whatever we tell them to do at home. So all the things like sleep pattern, the eating habits, the support of the spouse, the financial condition, the interventions available, all this needs to be included in your evaluation. And this will lead to some practical help and services for the child and the family. So evaluation is not to put a label, not for a school admission. That can be done as a formality for whoever needs it. But ideally, an evaluation should have all these things which will help a child and a family practically to move ahead in the interventions. So who should do it and how should it be done? Well, yeah, we know it's multidisciplinary evaluation, but not easy, or neither is it logistically possible to do multiple disciplinaries with different people at different places. So anybody who can evaluate multiple domains of a child's development is good enough to do an evaluation. And who best plays? The developmental pediatrician, a pediatric neurologist, or a pediatrician who has some training in neurodevelopment. But we need to counsel parents that this is going to happen only after a period of observation. They can, you might have to send some videos of how the child is doing at home, because sometimes the child may not do much things in the clinic. So direct observation along with the videos, many places, multiple times observations And the evaluation has to have two key components. The parent interview or the parent questionnaire is very small part. The direct observation, either observing in the clinic at multiple times or various videos, will help to come to a diagnostics of a disorder. In fact, any tool which will help you to go through this criteria will give you an evaluation. And there are many, many tools available, CARS and ISA and CLAIM. And anything, and these are all very simple tools to go through. It's all self-explanatory. A little bit of going through them, a little bit of help, and anybody can, any of the pediatricians who are well trained in child development can go through these diagnostic criteria and give a diagnosis. Now, ideally, all this has to be gone through. When you talk about evaluation, it has to be a complete evaluation. Of course, developmental, medical, family, social histories, information from school, clinical observation, and the diagnostic tool. And then there are all these various IQ testing, language testing, testing of the child's adaptive skills, sensory skills. These are all standardized assessments, forms, which are very easily available. Evaluation of the medical conditions, the constipation, the sleep, the convulsions, and then etiologic evaluation as needed, the genetic testing, as and when is indicated, imaging, metabolic test, EEG, only when indicated. So when we are trying to give a label, a lifelong label to a child, it can't be taken lightly. It has to be given with a parent interview, observation, integrate everything, and give domain-specific level of functioning and severity. Now, what does that mean? A child who might be very good in communication, in speaking, does not and is very, very poor in social skills, or a child who is able to do rote academics might come across as a mild autism spectrum disorder when we do the questionnaire, but in fact is not able to function independently in daily life. That doesn't put him in the mild category. So there are all these features which are mentioned in the autism spectrum, social communication, all these interests, but each one of them will go on mild, moderate, severe, minimally verbal, good language, fluent language, needs independent, needs support, etc., etc. And when we get results like this, so this is one of the recent results which have gone, where the child was referred to a psychologist for evaluation of autism. And this is the report that he got. The child's score was 90. This is ISA, Indian Scale for Autism Assessment. And the total score was 90, which puts him in the mild category. 70 to 106 is mild category. And what the psychologist told them was the child needs behavioral therapy and reassessment after 6 months and then every 6 months to see what is happening to the score of 90. So when you are giving a score of 90, there is no understanding or no counseling of where the child's symptoms are lying in different areas and where does the child need to, where does the intervention need to work. And what my worry is when a child is going to be reassessed in 6 months' time using the same, if this score 90 becomes 86 or the score 90 becomes 95, there's going to be suggestion that the therapies are working, or there's going to be a suggestion if the score goes from 90 to 95 that the child needs some other therapies in addition to behavioral therapy. So I think we have to be very careful when we refer this children to professionals who may or may not have total understanding and are working only with questionnaires. And on a different note, when I asked this mother about what she understood by this, what she told me was what she understood that the child's IQ is 90. So the whole counseling which was done, that instead of the score being 90, she understood that the child was, the IQ test was done and that was 90 and that was very good. So obviously the whole point of this evaluation was completely lost. So what does autism spectrum disorder look like? It is not linear. This is not severe to mild. There's a lot of permutation and combination of skills, and there's a lot of endless variations. There are things which keep on happening, and it may look more like this. It may look that the child might be better in perception, various areas, and that is why different children look differently in autism spectrum disorder. And just to summarize, so let's not hurry into labels. Diagnostic labels are not needed for interventions. Evaluation, which is based after observations over a period of time, is much, much better than which is based on just a questionnaire. over a period of time, parents do see improvements because intervention should have already started without a diagnostic label. It allows acceptance, it allows compliance with treatment. A blanket getting a mild, moderate, severe labels are completely useless for prognostication or functioning in each area, and functioning in each area is important. As we say, there are many tools for evaluation. There are, let us familiarize yourself with any one of them. But as we say, for everything, it's however good the car, it's the nut behind the wheel, the operator. So however good a test, unless and until the person who's doing it and how he's doing it knows what he's doing, the tests are quite useless. Thank you very much.
Thank you very much, ma'am, also for clearing the air on virtual autism. Ma'am, one quick question. Since majority of our audience today comprise of general pediatricians, what is a must-know tool for screening for autism for all the pediatricians?
Right, Shweta. So I think we, as we mentioned, MChat is the one which is very commonly used. There are many screening tools, but I think MChat is something which we have been going through with ECD and our TOTs as well. And it just takes a few minutes. It's available in different languages. It's free. There's online support as well. It's self-explanatory. There are, anybody can do the MChat. But what we need to remember that it is a screening test. It is standardized from 16 months to 30 months of age. So it's one of the good tests to do at a first booster at 18 months of age.
So, ma'am, any other checkpoints other than the 18-month visit?
So it depends. So the developmental surveillance should carry on. And then screening tests can be done at 9 months, 18 months, maybe 36 months.
Thank you very much, ma'am. Always a pleasure to listen to you as well.
Thank you,
Moving on to our next speaker. Our next speaker for the day is Dr. Leena Srivastav, ma'am. Yes. Sorry. So Leena ma'am is the chairperson of the IAP chapter of Neurodevelopmental Pediatrics. And she's the head of Developmental Behavioral Pediatric Unit at the Bharatiya Vidyapeeth Medical College and Hospital, Pune. She's also a visiting consultant at Cloud9 at LMCCH and COR Pune. She's a guide and coordinator of the IAP and the BVDU Fellowship in Developmental Behavioral Pediatrics program. She was the honorary IAP fellowship. She has an honorary IAP fellowship in childhood disability and in early intervention. She was the honorary secretary of the chapter of the neurodevelopmental pediatrics of IAP from the year 2018 to 20. She is also the national convener of the IAP module for post-scholastic performance program PSPP 2.0, the joint national coordinator for the IAP module for neurodevelopmental disorders. She's also the West Zone convener for the IAP module on race in high-risk newborns and the academic editor for the IAP Handbook of Developmental and Behavioral Pediatrics. Ma'am will be speaking today about the various evidence-based interventions in autism. Over to you, ma'am.
Good evening. I think Dr. Sameer and Dr. Leena have just given me a head start, and it's surprising how similarly or in sync we think, because it's almost as if they've set the stage for my talk. At the outset, I thank respected Dr. Khalatkar, the President Sir, the office bearers of the NMAP, and my esteemed co-faculty for planning such a relevant and comprehensive CME. And I will go directly to the talk. So I think we've already had a head start, and everybody's spoken about what we in India are doing, or we should be doing, or what is more relevant in a country like India. So while we talk about interventions, we read a lot about, basically there are two types of interventions. And one are the comprehensive treatment modules that we hear about in the West that, are more comprehensive. They encompass all the goals, and they are, carried out for a prolonged period of time. We may read about the early start model, Denver model, etc. And then we have focused interventions which target specific developmental outcomes and are carried out as and when the need be. Now, we hear about a lot of behavioral models, whether it is the ABA or the TEACH or the floor time or the NDBI, etc. But in a country like India, I don't think we have too many comprehensive treatment models. And so what happens in our place, as the earlier speakers have already said, are mainly that we have focused interventions which take up discrete goals and work on them. And that, I think, is the main, gist that we need to learn, that as pediatricians, we are the guide who will set the stage or help the parents keep these goals in sync. So instead of reading or studying the models in detail, as pediatricians, as developmental pediatricians, let us remember 4 very major points that will help us understand or monitor or give our children developmental goals in an intervention plan, and how we go about that. Now, these, I think, first begins with identify and understand goals. And I think a lot of what my previous speakers have said will come into the picture again and again, but then it means that we are all speaking the same language. So when we say identify and understand goals, we must remember the core symptoms. We must remember that every child has these features or comorbidities in different severity and presentation. And that is why no 2 children of autism look the same. And that is why, as Leena told us, having this does not mean there is autism. Not having this does not mean that there is no autism. And that is why no 2 children will have the same intervention as well. So how can we have the same intervention for each and every child? We have to have different goals. And that is why we must remember, as I think Samir has already told, that the social reciprocity or the social engagement remains our first core feature missing in autism. And that is what our basic goal would mean. And then going on to non-verbal, and then verbal, and then developing and maintaining relationship. I think it's all there for us to see. It's only about us realizing that intervention basically means what is missing and trying to developmentally, appropriately, in the sequence that we have learned as pediatricians, put those goals into place. Now, another point that I would like to highlight here is that these functions that we are focusing on should also limit and impair everyday functioning. In fact, many a times we see that there is hypotonia, so we're working on the hypotonia. But then, is there any functional impairment? If the child can do all his motor functions well, do we really need to focus on his hypotonia? Okay, so what we must remember is that when we are planning a goal or a modality, it is also important that is there any functional impairment that symptom or that problem or that examination point is actually causing in the child. If not, we don't need to target it, right? So that is something we must remember. Then again, with the core features, we must remember the comorbidities. Like Leena said, sleep, I think, is extremely important. And once you solve the sleep problem, not only in children with autism, I think most younger children, they are not getting their required amount of sleep. And that definitely plays on the behavior, not only of the child, but of the whole family. Everybody is more snappy. Best of us are too. So working on these comorbidities or considering them also as part of our intervention plan is very important, because each and every aspect, as Leena put it so beautifully in that last picture, are all playing a part in the whole spectrum. And that is why everything is important, whether it is the cognition, whether it is the epilepsy that the child also has, whether it is the constipation which is upsetting the child and causing worse behavior, and of course the behavioral problems that we see anyway. Okay, along with the language and all the other main domains that we are thinking of, or the parents are prioritizing. Now, again, I think even simple things as pediatricians about the dental health, the pica, a lot of these children will have these problems also. Malnutrition, because of their, fussy feeding habits, many of them may have malnutrition. In fact, some of them may have, he eats only chips. Isliye we give him a tub of chips every day, and you have these really obese older children also. So it is not only malnutrition, you may be dealing with obesity, and I see Dr. Gavani has that obesity thing highlighted today. So I would say that, every neurodevelopmental disorder also can come with, that package it's not always the, that they are fussy and so they don't have nutrition. It depends on how we, reinforce their feeding habits. So once we know that what are our goals and how we understand what are the domains, which I think my previous speakers have made very, very clear, then we need to plan and prioritize these intervention goals in every child. And for this, I'll just take you through very quickly a spectrum of cases. Okay, now you have the younger child, which everybody's spoken about. We know that's the prototype of case we see when we see a child who parents are concerned about two things. One is the speech delay, one is the hyperactivity. But when you see the child, you see that that's not only that, there are so many domains involved. There is so much more to that child that is lacking in his developmental goals, apart from the two things that are priority for the parents. And you see that the fine motor is not good enough, the verbal, non-verbal, both non-verbal before the verbal is, lacking. The social is absolutely not in place. The child is not engaging with you at all. And activities of daily living. You can have a 6-year-old child with autism and just ask if he eats food on his own, and 99% the child would not be. So that is also such an important thing. You notice that the child has pallor, iron deficiency anemia. So obviously that remains to be, corrected. And as Leena also put it, your observation, your behavioral observation is one of the primary things that actually tells you what needs to be worked on. And this child is all over your clinic. He's running outside the room. The parents are running after him. He's, just keeping on engaging in some repetitive activities and not looking at you at all, even when you offer the best of things to him. And I think the most dangerous part is his running away outside the room, because that turns out, wandering away turns out to be a very big safety matter, because then, the parents are not even comfortable with leaving their children outside with somebody else because, they're worried about the safety. Now, again, as we said, the interventions in these child would encompass everything from the sleep to the behaviors to the social engagement, which probably would be the primary goals of this child. But I think for a younger child, to initiate and to engage the child well, play is one of the easiest and one of the best modalities. And it is very important, and I love to review videos of how is the child playing. And we know that most children of features of autism will not engage, not have good pretend play, not have good imagination. They may learn eventually to make the doll sleep, but in a very learned kind of a manner. That spontaneous pretend play and engaging play does not happen. And so I think what I would like to say is, for younger children, one of the very, very important goals is age appropriate, interactive and reciprocal play. And who knows play better than a pediatrician? We actually child should be playing, what is the age appropriate play for the child. And I think that is something we can always, so sleep and play for younger children, I think are very, very important goals that we must remember to include in our intervention plans. Now let's quickly go on to this older child. We're not going into details of the evaluation, etc., as we've had talks, but he's a 6-year-old who came mainly with academic concerns. He is in standard first, and the parents say, oh, he was, during the lockdown, he was at home, so he didn't learn. So all his academic difficulties are actually because, these terms now, parents have got terms like COVID babies and then, preschool lockdown babies, and I don't know, all sorts of things. But if you actually go down into the history, now these are educated parents that we had, and if you go down with the history, the child actually had global developmental delay. And again, very importantly, your behavioral observation showed that he had all the features that we would call probably having autism spectrum features as well. But the global developmental delay had actually gone unnoticed. And even though this child turned out to have mild ASD, the primary thing was a global developmental delay, which now, as the child was already 6 years old, has now gone on to have cognitive impairment or mild intellectual disability. And it is not only the IQ, but the adaptive functioning, which could have easily been optimized when he was younger. And as we see here, even his SQ, that is his independent living skills, are so much lower. So it was not the academics that was important, but it was the cognition and also his adaptive living functioning skills that really needed work when he was younger. but then they had been missed. And that is why in this child, along with all those goals, even though we are already on the outer age of 6 years, where you can really make a difference in the initial years, and we talk so much about early identification, there are so many of these global delays also that you miss. And here again, with the intervention plan, it is also important for us as pediatricians to look in the etiological workup, because there could be neurological disorders, there could be genetic disorders which could have a repercussion on the family, and they need to be counseled about that depending on the family setup and the economic situation, etc. So we must remember that almost 30% of children with autism spectrum disorder will have intellectual impairment. And that is why we don't wait till 6 years of age when we notice that there's intellectual impairment. We make cognitive development and adaptive daily functioning skills goals in the initial years itself, to optimize these domains to get better outcomes and reduce the impact of the intellectual impairment as these children grow up. Okay. Now the third child quickly is an 8-year-old child who came mainly with behavioral concerns reported both from school and from home. This child seemed to be very intelligent. The parents say otherwise he's well, he's been doing well, etc. But again, your behavioral observations, the most important part of any evaluation, the behavioral observations, as Lena also highlighted, again, you notice that he's socially slightly naive when you talk to him, on converse with him. And of course, he has a lot of behavioral fidgetiness and, not sitting in one place and attention, which sort of surprises and doesn't go with his cognitive, abilities. And true to that, his assessments do indicate that he seems to have a very good IQ. He seems to be doing fairly okay in his academic achievement as well, except for his expression. But his adaptive functioning is slightly low, and he does have features of mild autism spectrum disorder, along with some attention deficit hyperactivity disorder as well. Now, this is an 8-year-old child, and you would wonder how come he's not been diagnosed all these years, or how was this diagnosis missed? And many a times we see that when children come with normal cognition to us when they are younger, many people dealing with the children do not, entertain the diagnosis of autism, because the child is doing cognitively and language-wise better or fair enough like his peers. But you must remember the definition again, that symptoms must be present for early childhood. It may, actually present to you only when the demands and expectations from this child do not match. So it is not that every child with autism will have really poor cognition or will do really bad in academics. Always keep your eyes open and remember that even good cognition children can have these features. And as they grow up and when our social demands from them keep on increasing, this is the time when, they actually face difficulties. And it is so difficult counseling the parents after all these years. And I think we've seen a spate of them after the lockdown, which have been missed, and a lot of their difficulties have been attributed to the lockdown. And then, we have seen that they actually had features of autism all through, and now, they've grown up so much that undoing their social learning and teaching them again becomes so difficult. So we must remember that co-occurring behavioral symptoms, whether it is hyperactivity, inattention, aggression, ADHD, all these things are also common in children with ASD. And we must remember that normal cognition, as you think about intellectual impairment, also should be thought about in children with autism. So as long as they are functioning well, many a times we may not notice it, but asking open-ended questions and being open listening about their functioning in school, at home, at their friends' houses, in the community can, really give you good information. And the functioning part, again, should be what our intervention should be targeting. Now, the last case in this would be a 16-year-old child who had autism all through, has recently come to you with some behavioral changes. And you see that when you're talking to her, she seems really low. You've seen her all through. And yet you find that, she seems very disinterested this time when she comes to you. So remember again that children with autism, as they grow into adolescence, may have depression, anxiety, also as comorbid conditions. And here, along with your interventions, in fact, you would have to prioritize the depression or the mood in a, initially to first help the child on that front, because that would be your urgent intervention goal. So whether it is a younger child where the behavior, the play, the social engagement or sleep is the priority, or in older children where they present with academics, but you have to look at other problems that the child would, actually be functionally facing, or in older children where you may have ADHD or anxiety or depression, keeping your eyes open for comorbidities and making them your intervention goals is very, very important. And we have a lot of adolescent experts also in the audience that I can see. And so obviously screening them is very important, and being aware about them is very important. Now, third point would be individualizing your goal. As we said, no two children are alike, and we know that there are evidence-based interventions, but you can't have the same kind of therapies or the same kind of intervention or the same kind of goals for everybody. And so, as we all spoke about initially, and, again, I would like to highlight that most parents are focusing on the speech part or the academic part or the fine motor skills part. And then it becomes like, the earlier elephant grows very disproportionately, and you have this child with a lot of speech, which may be echolalic, which may be rote learned, with a lot of academic skills. But then the primary problems, as Samir also highlighted, of the social behaviors, their activities of daily living, which I really find lacking in these children most of the times, because of a lack of expectations more than anything else. The behavior, the play skills, the cognitive skills have not been looked at. And so again, there is this disproportionate elephant, with those core areas remaining small and developing only speech and academic goals. So it is very important that when you are planning early intervention, it's not only the early, but it is developmentally appropriate and encompassing all the goals that should be. And it is not only about a multidisciplinary team, it is about having the multidisciplinary team in sync. And I think that is where it is very, very important. The role of a developmental pediatrician or a pediatrician who has enough time to sit down and actually, help review these goals is, the crux of a good intervention plan. Goal that I think we must remember is follow-up. Everything starting off early, planning the goals, but no follow-up, and then many a times the whole battle is lost. Okay, and for that, let me quickly highlight two cases. Here we have a child who's come at 2.5 years of age, so very early, very nice. He has typically the features that you find that you set high risk for autism, but then he gets lost to follow up. So when you see him at 2 years, 6 months, he has a delay on screening in fine motor, communication, problem solving, personal, social, with an MCHAT showing high risk for autism, but then he goes off, does therapies, never comes back to you again. And now in Feb, we see him again when he's 4 years, 5 months, and here the delays are all still intact. The SQ, which is the adaptive living skills, is really low, 43. Communication, he started saying a few rote learned words, but not enough functional communication. Behaviors are still as bad. And now obviously he is in the diagnosis of autism with all the functional levels really low. And to contrast that, my last case is this other child who came at 3 years, who had in fact worse behaviors than the earlier child with the same spectrum. And he came at 3 years. So you would say, oh, he's come later than the earlier one. But this child and this family had regular follow-up. As you can see, initially, he does have a delay in all the domains with very poor functional communication, with a lot of behavioral problems. But as the years go by, you can see that most of his domains have come into the normal range. Even his problem solving, he's actually come into a normal IQ range. His SQ, his adaptive functioning skills have come age appropriate. His communication is coming up. We did start medication on the way, but in fact, now recently his IQ, SQ, everything has come into, average ranges. His communication skills are much better. His social behaviors are better. My medicine is being tapered now. And the ESA score, as Lina put it, obviously has to be seen in perspective with all the other functioning, and that is coming down, and we hope to come out of the spectrum, as a lot of children actually do, for all of us who work with these children would actually see. But then, of course, I send them off with a pinch of awareness that during adolescence, when these children face a lot of peer pressure and, higher demands on their functioning. Even children who have shifted out of the spectrum could face challenges, and it's necessary to keep a follow-up. So again, the take-home messages would be pretty much what my earlier colleagues have already said, that even being a single diagnostic category, there's a lot of individual variability. So we cannot have goals that would be the same for any two children. The comorbidity should be a very, very important part of your intervention goals. Intervention should start, as IAP community health guidelines and the parental guidelines have said, with at least a provisional impression or a diagnosis. They should be developmentally appropriate. They should be structured and appropriate for the developmental and functional needs of the child in association with the family, because every family has different priorities, different demands, and different settings in which these children are brought up. So it's very important that we sort of take that into perspective as well. So last but not the least, as a pediatrician dealing with children and families, I think you're the nodal person that the family comes back to, relies on for advice, relies on for support. And I think support and empathy remain a very, very important part of the intervention plan. And I just love this quote, and I'll take a second to read through it, that always remember that step into my shoes and walk the life I'm living. And if you get just as far as I am, maybe you will see how strong I really am. So we owe them the support that the parents need when they are on this journey. Thank you.
Thank you very much, ma'am. Ma'am, could you tell us a quick word about the role of medications in autism and how many children require it, and for what symptoms do we usually prescribe medications, if we do?
So basically, of course, the intervention is the main part, the non-pharmacological intervention. The pharmacological interventions may be used especially for the comorbid kind of conditions, like whether it is the behaviors or the repetitive behaviors also, which are a core symptom, but then they can be controlled a little more with medication. So it's mainly the comorbid conditions when they interfere with the teaching learning of the child is when medication should be used. Medication has to be used in as part of the intervention plan. Again, not that, they prescribe medication and they're lost to follow up. So whether it's sleep, whether it's behavior, whether it's anxiety, depression in older children, they have to be used in tandem with the intervention goals, because finally, it's not a long-term plan. Medications is usually a rescue to help the teaching learning become better. And that is why it should be used as a short-term rescue most of the time.
Thank you very much, ma'am. Moving on to our next talk, our next speaker for the day is Dr. Shambhavi Sheth. Ma'am is a developmental and behavioral pediatrician. She has got her PG diploma in developmental neurology and was awarded the honorary fellowship in childhood disability and early intervention by the IAP. Ma'am has more than 20 years of experience in pediatrics, with just more than 13 years in developmental pediatrics. She's the Joint Secretary of the IAP Chapter of Neurodevelopmental Pediatrics and National Coordinator for Fellowship Program in NDP. Ma'am is currently the Senior Consultant at Max Healthcare and Rainbow Child Health, Delhi and Gurugram, and is the Director of Bright Beginnings CDC. Her areas of interest include parent-guided interventions in autism spectrum disorder and high-risk newborn follow-up. Ma'am will be speaking about the role of alternative therapies in autism. Over to you, ma'am.
Thank you, Dr. Shweta. I think this was probably an old introductory slide, and I'm right now the secretary of the chapter, and graciously, I think I will move forward to the presentation. And I think today, every day, everyone is going to dream about autism. Probably it's past, few minutes past 10, and we are online on a webinar on autism. That's great. And we have some 60 plus audience still. So the topic given to me was complementary and alternative medicine. And at the outset, I would like to kind of do a disclaimer. This is not my thinking. This is what the evidence says. This is what the data says. This is what the research says. And how over the presentation, we are going to see how do we balance this evidence with the practicality. So let's start. So right now we know the autism, the developmental disorders are on a rise, and recent CDC data in 2023 has already said almost 1 in 36 children are suffering from autism. So we also know when we talk about NDD, there is no single factor when what we have come as far as it's a multifactorial origin. It could be genetic partly, it could be environmental. And so that is why we are not able to put a single treatment as the treatment option for every child, because each child who's presenting to us is different. We also know these NDDs are very chronic in nature. Once a diagnosis is given, probably it's a lifelong. And it's a huge, not only a financial burden for the families, but also emotional burden and a social burden. So the families are looking for something which may be a little quick resort. And as the society, we always feel unless a medication is given or a pill is administered, nothing is going to work. So we feel the pills work faster. And of course, there is a bombardment of Google Baba, and each and every family who is being diagnosed or suspected autism, they have already Googled, they are already into so many other kind of therapies, which even they may not kind of inform the pediatrician. So coming to that, after this, so it has led to resorting of treatment options, which may be quicker, cheaper, pill-based. They may also think it's more natural or traditional, some of these complementary and alternative medicines. And where is the evidence? That's what we are going to see today in our talk. So by definition, by Cochrane collaboration, the complementary and alternative medicine is a broad domain of healing resources that encompasses all health systems, modalities, and practices, and their accompanying theories and beliefs other than those intrinsic to the politically dominant health system of a particular society or culture in a given historical period. Just to simplify, we as a society or as a culture, we are more allopathy based. And so anything which is beyond this probably is going to fall into a complementary and alternative medicine. So what is the prevalence of CAM usage? A lot of studies are there and which may show a variable prevalence of these CAM usage, and almost 1/3 of patients with autism, 64 patients with ADHD may consider CAM as an option. And the current estimates are to believe from 19 to 57%. Closer home, there was a study from South India by Uday Kumar et al., which was published in India Journal of Pediatrics in May 2020, where they had studied around 213 families and almost 20% were exposed to one CAM. The most common CAM was the herbal medications, then the Ayurvedic medications. And interestingly, in this study, they also found that 56% of parents and caregivers did not discuss about the usage of CAM to their child with the pediatrician. So imagine a family is coming to us and being managed by us, but they're still not disclosing the child is on CAM. So how it is going to affect, how much it is going to affect, we really don't know. The CAM can be classified as biological and non-biological. Directly acting in the body, the biological includes the dietary interventions like GFCF diet, dietary supplementations like vitamins, omegas, hyperbaric oxygen therapy, and chelation. The non-biological CAM may include like allied disciplines like mind-body medicine, yoga, meditation, music, dance therapy, manipulative and body-based practices like sensory integration, massages, auditory integration, energy medicine like Reiki, and alternative medical systems like homeopathic, traditional Chinese medicine, and Ayurvedic medicine. So instead of kind of going into each aspect of CAM separately, so what the research evidence is I've kind of collated. So currently, the most of the evidence for the CAM therapies are the uncontrolled studies where the proper randomization and control group is not created, or there are open label trials where the subject and the family knows what is being given. So the chances of bias is high. There have been a couple of more RCTs and double-blinded studies in last decade, but they have all very smaller study samples. And a lot of meta-analysis are also available on CAM, but most of them are also, one of the bigger ones was to study 2,687 clinical publications by N. Brondino, and association of comorbidities and different therapies which the child is already taking may have rendered the interpretation difficult. So a lot of this research applies to different disciplines of CAM. where we all see that these are the things which we commonly see in when we study the evidence on CAM. Now, coming to a few CAMs which I would like to discuss in more detail. One is the GFCF diet. A lot of pediatricians ask us whether this is recommended. Parents are very, very keen to start a GFCF diet. But what it is seen is basically it is the gut-brain axis, and it is seen the specific allergen which is present in casein or gluten, which may trigger some enhanced immune response in children with ASD. And this was the basis of starting the GFCF diet. But currently, the double-blind clinical trials have not demonstrated any effect with the diet. There could be some improvements in some children, and that could also be seen because of the removal of dairy. And there is because the child may have been lactose intolerant or maybe protein allergic. So which may be kind of contributed to GFCF diet, but actually it was not because of the autism part being improved, but the behaviors were improving because the child was lactose intolerant and the family now has stopped the milk. So this is the gut-brain axis, and we know the brain affects the gut through various means, in improving the blood flow, permeability, motility, and also the gut which has the microflora also affects the brain through the enteric nervous system, autonomic, cytokines, and neurotransmitters, which increase the blood-brain barrier and may also have the direct effect on the permeability of this membrane and affect the brain in a child. So this gut-brain axis is there, right? There is no debate about this being not there. But the only thing is when we talk about an exogenous source like a microbiota or an external probiotic, how much it is going to be bioavailable, how much it is going to actually influence, that becomes the debate. So the multiple studies are again there on the microbiota or the use of gut probiotics. And one of the meta-analysis which was done and published here, this is the reference. I would just like to quote all the types of probiotic supplements administered in the trials. They were from different dosing, different form, different bacterial strain. Comparing the studies of monostrain versus the multi-strain probiotics were seen better. There have been a clear trend that there may be certain differences in the behavioral patterns of children with autism, but still what we need is the comparison is still difficult. And right now what we are at this juncture, we need more randomized control studies with a larger population size to comment and do it more and to advise it in every child. Now coming to one of these favorite is the omega-3 supplements, which is really, really being very, very commonly used. And there have been control studies for omega-3 with placebo, and there's been seen no significant differences reported between the use of omega and the placebo. And moreover, the dosage of omega supplement is also been very variable. It is not standardized what is the ratio of EHA, DHA, and how much omega actually has to go in. And the other supplements include, which are B12, B6, L-carnosine, herbal medicine. All of them come into a category where further research is needed to advocate their clinical usage. So now coming to a newer molecule, which has been there for last 2-3 years, and which is the sulforaphane, and it is present. It is a phytochemical which is found in the cruciferous vegetables like broccoli, cauliflower, and kale. And I think we kind of generally are biased when we see these green leafy vegetables and we think it's always good. So the mechanism is the antioxidative stress, which is the direct effect of sulforaphane, and they help in alleviating the symptoms of autism through this, and also DNA methylation is affected. And they may improve the social interaction, abnormal behavior, and verbal communication in the studies, which they have studied. So then again, there have been multiple studies for this compound. And one of them is a meta-analysis which has covered 5 studies. Of the 3 were the RCTs and 2 were the open label studies. And they showed a significant improvement with behavior, social, and cognitive scores with sulforaphane use. And in most of the studies, it was a well-tolerated agent. But limitations have been, there is a short duration period of these studies, around 12 to 30 weeks. The small sample size is there. There was a conflict of interest in one study of the 5 studies which was quoted in this meta-analysis, and 2 were open label studies. We already know they may have a higher chances of bias. And in fact, one study said the positive effect was reversed after the stoppage of the medication. Another recent study on this was in the year 2023, and they had found it was an RCT where they had found there was no significant clinical improvement in the behavioral outcome measures for these children from 3 to 7 years who were treating with sulforaphane. So again, this is where we are, where we need more studies to advocate its use in general population for all children with autism. Now, coming to vitamin D and autism, again, vitamin D, we are managing a lot of our children with vitamin D because 90% of the urban population and in fact rural also is deficient. But we stick to doses of 400 to 800 IU per day. But there have been rounds about mega doses of vitamin D, which is 300 IU per kg per day for children with autism. But again, the meta-analysis, which was published in Nutrients 2021, had said it's the variations in vitamin D dose protocols has been there. The smaller number of subjects are there and shorter follow-ups. And we also don't know the long-term effect of the vitamin D toxicity if present in these children. So we don't recommend a mega doses of vitamin D as of now, and only the deficiency part of vitamin D, as we routinely do in our pediatric practice, is recommended. Hyperbaric oxygen and chelation, may have potential, in fact, to cause harmful effects, not recommended. So a lot of these CAM, the evidence can be classified as either emerging or unestablished. Clearly, unestablished evidence has been there for interventions like auditory integration, GFCF diet, sensory integration, animal-assisted therapies, movement-based therapies, and sense theater interventions. Whereas therapies like massage or touch therapy and music therapy, the evidence is currently into an emerging category. Now, coming to the stem cell therapy, I think I would really like to highlight a bit more because a lot of new evidence has come. And one of the important documents is the Indian Council of Medical Research in 2021 had a detailed document about the usage of stem cell therapy in different medical problems, and one of them was autism. And the recommendation had said that based on the review of available scientific evidence, the stem cell therapy should not be offered as a standard or routine therapy to patients with autism. These guidelines will be periodically reviewed as per the evidence which is going to get available. The shortcomings, the ICMR document also has detailed 9 studies which they have taken from a period of 2013 to 20. And most of them have the shortcomings were they were not double-blind randomized. They had smaller number of patients. The absence of long-term follow-up data is there. A lot of relying on caregiver assessment for the benefit of stem cell therapy is seen. And a lot of these patients who are subjected to stem cells, they actually are also taking interventions pre and post. So we really don't know what impact has been brought by the stem cell per se, or whether it was the progress through these interventions which the children were already taking. I would like to go ahead further and mention about the cautionary note which the ICMR document says. And it says that the stem cell therapy is only restricted to clinical trials, and the participant should not be made to pay for any expenses for it. There has to be informed consent. And in fact, if there is any side effect or any harm, they should be also provided compensation. So all this knowledge is very important, and these are what the current guidelines in India say. And there have been more recent work on stem cell published in October 2023, again, which is not showing any strong clinical evidence for the stem cell support in children with autism. So as a lot of references I have, if anyone would like to go through detail, I am happy to share with them. So now coming to what is our role as a clinician when we talk about CAM and discuss with the families, and how do we balance the evidence with the practicality issue? So while I feel when we are talking about these CAM interventions, or the parent has kind of put forth a question, so we should always give them the latest research evidence which is there and explain to the family. There may be few options which are safe, and they may not be very costly or not burdening to the family in terms of finances. So the family is free to use them, though even if you have explained the evidence. but they should always be used as an adjunct therapy. They should not be replacing the conventional, the evidence-based interventions which the child is subjected to. And I personally feel a family, even they have to try, they should try one option at a time, because if they try multiple things together, homeopathic also, GFCF also, then they don't know what has worked and when to stop it if it has not worked. So I think as a clinician, we should strongly discourage the CAM therapies where they have a potential to cause harm to the child. And we have to be very, very strong and emphatic in explaining that to the families. So in the end, I would say CAM is not a scam, but we do need more evidence-based research where we can support the as and when it comes, we support. But I would like to end my presentation by this meme where this is a girl who's saying, would you like a doctor who offers evidence-based medicine, holistic medicine, or personalized medicine? And the guy is saying, I'll take the one who does house calls. So I think whatever we talk on this scientific forum, ultimately the practicality and the choice is with the parent. But thank you all for your attention. I would like to also mention the IIP Handbook of Developmental Behavioral Pediatrics, which is a very good resource. And we have multiple chapters and also a chapter on CAM written in this. Anyone can use it for reference. Thank you. Thank you, everyone.
Thank you very much, ma'am. A quick question for you as well. Ma'am, apart from the routine occupational speech or behavioral therapy, I was just wondering, are there any of these alternative therapies that parents have really insisted on and you have told them, all right, give it a go? Any of these alternative therapies have you suggested as well?
So, yeah, right. I think that's a very practical question, because in my practice, I'm not proactively writing any of the medications or Omega, but a lot of families have already been started on Omega. And I will definitely tell them there is currently no evidence to support this. But if the family is still very keen, I would say it is up to you. I don't know what benefit it is going to actually lead to the child, but it may not cause harm. So if you want to try for 2-3 months, you are free to do. So that's what I kind of practice with my patients.
All right. Thank you very much, ma'am. Over to our last speaker for the day, Dr. Rupa Srinivasan, ma'am. So, ma'am is the Senior Director of the ECD Programs and Clinical Services at Umeed Child Development Center, Mumbai. She's the course coordinator and faculty of the IAP Neurodevelopmental Pediatrics Fellowship Program at Umeed. She has also been the project director for the National Institute of Health funded multi-country research projects between 2010 to 14 and 2020, and the project is still ongoing. Ma'am is also the member of the steering committee for International Collaborative Office Rounds, which is a training initiative of Society for Developmental and Behavioral Pediatrics, and a member of the secretarial board of International Developmental Pediatrics Association and scientific and organizing committees of the 2nd and 4th International Developmental Pediatrics Congress. She also has various publications in national and international journals to her merit. Over to you, Dr. Rupa. Her topic is basically most of these parents and families find it very daunting. It burns a hole in their pocket, the whole journey from diagnosis to seeking therapies and where to seek, which is the most cost effective. So she is going to shed some light on what are the various government schemes to help these families. Over to you, ma'am.
Thank you so much, Shweta, and really appreciate everyone staying back so late in the evening. As Dr. Shambhavi said, it's well past probably many people's dinner time and probably closer to their bedtime. So really appreciate everyone staying back. Heartfelt gratitude to the Navi Mumbai Association of Pediatrics for putting this program together along with the IAP Neurodevelopmental Pediatrics chapter. Thank you so much to Dr. Leena Deshpande, Dr. Leena Srivastava, and Dr. Shambhavi Sheth once again for putting this program together. With that, I will not keep you waiting anymore and quickly share screen to talk about the topic that Dr. Shweta mentioned. I'm just going to quickly check if I have shared sound. Apologies, just going to do that once again. So at the best of times, when we are talking about government schemes, when we're talking about rights, And we've all been in this situation. Of course, we would probably know about the government schemes. We know that they can help the families. But the background thought in our minds is, this is not what I was trained in. This doesn't seem like a clinical topic. How is this relevant to me, and what do I do over here? And on the parent's part, of course, the parent is thinking, I understand that therapy is really important. I get the doctor's message, but I have so many struggles. And when somebody talks about rights, I don't see myself as an activist. And in fact, anything that has to do with fighting for rights or getting something from the government seems like an uphill task. And the quiet thought that might come in most parents' minds is that ye hamare bas ki baat. So what does one do over here in such a situation? What are some practical things that all of us can do to help children? But even before we get there, let's even understand, how do these rights and entitlements really help children with autism? So this is the outline of my presentation today, which is to talk about the rights and entitlements in simple and easy to understand terms, and also some simple things that you as a pediatrician can do. So what are parents usually hoping for? And I'm beginning over here because often this is the hook for parents to start thinking about getting that disability card, trying to engage with institutions that offer these services, or to even think about rights and entitlements. So when you ask parents about what are their hopes and dreams, the parent is often going to say, I'd like my child to be educated. I'd like my child to learn. I'd like my child to have friends, interact with other children, just like any other child. I'd like my child to have everyday experiences just like anyone else does, and live a happy life. And I've heard this time and time again from parents. And living a happy life could involve so many different things. And for children with disabilities in general, but more so for children who have autism, the environment around them plays such a crucial role. So these concentric circles around the child and youth are all signifying all the people and different stakeholders who have a big influence on the child's life. It begins with the parent and immediate family, goes on to institutions like schools, goes on to neighborhoods and communities. And the last concentric circle that you see over here is actually talking about the cultural context as well as the policies. When we say policies, we're talking about the government policies for children with disabilities, or in this case, children with autism. So what are the rights that are relevant to children with autism over here? Three main and landmark rights that have been instituted by the government over several years. So the rights of persons with disabilities that came into being in 2016, the right to education, and the National Trust. Now, the topic for the day is to talk about rights in general, but also more specifically, how can this burden, the financial burden of availing of therapies and services, how can that be alleviated to some extent? And many of you may have heard of something called the UDID card, the Unique Disability Identity Card, that the government issues, the Ministry of Social Justice and Empowerment and the Ministry of Persons with Disabilities. And this card is meant to be used as a smart card in the future, where it ensures that the individual with disabilities is able to access provisions and schemes, and that the central agencies are able to track it. So who can apply for the UDID card? So persons with any of the 21 disabilities, which includes autism, can be covered under the RPWD Act, which stands for Rights of Persons with Disabilities Act 2016, can avail of the card. What is the process for getting the card? It's fairly simple. In fact, over the years, it has been considerably streamlined. So you have to fill up a very simple form on the website that I've mentioned over here, get the necessary assessment at a hospital. So once you fill up the form, the hospital that is designated in your local area is where the family has to go and get the necessary assessments done. And then after that, track the UDID application status. They'll also get the disability certificate. So what are some of the benefits that individuals with autism and other disabilities can avail of after getting the UDID card? They have benefits in the area of health, education, tax benefits, travel, aids and appliances. And when parents choose to apply for this, legal guardianship. So I have a very short video of parents who have availed of some of these services, just to give you a sense of how impactful something like this can be in their lives.
मेरा बेटा जब 3.5 साल का हुआ तब उसने कुछ अजीब सी चीज़ें की कि अकेले रहना शुरू कर दिया, लोगों में घुलना मिलना बंद कर दिया। तो मैंने जाकर डॉक्टर को कंसल्ट किया, उसको स्पीच भी तब तक नहीं आई थी। तो डॉक्टर को मैंने कंसल्ट किया, डॉक्टर ने मुझे बताया कि इस बिलाल को ऑटिज़म है। तो उन्होंने मुझे कुछ थेरेपीज़ वगैरह बताई कि आप यहाँ पे जाओ, वहाँ पे जाओ। तो एज यूजुअल जो नॉर्मल पेरेंट्स करते हैं अपने बच्चों को लेके भागना, वो मैंने किया। लेकिन जो थेरेपीज़ के जो बाद में समझ में आया, थेरेपीज़ करने के बाद समझ में आया कि स्पेशल बच्चे, इनके खर्चे जो है वो नॉर्मल बच्चों के लिए अफोर्डेबल, नॉर्मल पेरेंट्स के लिए एक्चुअली अफोर्डेबल रहते नहीं हैं। तो मैंने सबसे पहले बिलाल का UDID कार्ड बनवाया। उसके ज़रिए मुझे पता चला कि एक निरामया हेल्थ इंश्योरेंस आता है जो ऐसे बच्चों की थेरेपीज़ वगैरह में हेल्प करता है, जो उसके लिए मतलब पेमेंट आपको रीइम्बर्स करके देता है, जो आप खर्चा करोगे उसका वो रीइम्बर्समेंट करके देता है। फिर मैंने वो निरामया हेल्थ कार्ड बनवाया। हेल्थ कार्ड बनाने के बाद जितने खर्चे मेरे हुए उसके ऊपर, जैसे आप पर ईयर थेरेपीज़ के ऊपर 20,000 आप विड्रॉ कर सकते, वहाँ से रीइम्बर्स कर सकते हो। तो मैंने फिर वैसे ही किया। बिलाल की जहाँ थेरेपीज़ वगैरह चलती थी उसके सारे बिल्स वगैरह, डॉक्यूमेंट वगैरह जमा करके निरामया हेल्थ के ज़रिए मैंने वो पैसे वहाँ से रीइम्बर्स करवाए। मैंने 2 बार क्लेम किया, दोनों बार मेरे क्लेम पूरे आए। और मतलब ये काफ़ी एक पेरेंट्स के लिए एक बहुत ज़्यादा हेल्पफुल चीज़ है कि आप जो पैसा खर्च कर रहे हो, जैसे मैं 40,000 अगर साल का मैं खर्च कर रही हूँ तो मुझे 20,000 तो उसके ऊपर मुझे रिटर्न मिल रहे हैं। तो वो 20,000 भी उसकी थेरेपीज़ के लिए आगे मुझे काम आ जाते हैं। कि दवाइयों के खर्चे जो है वो भी मुझे मिल जाते हैं, OPD का जो खर्चा आता है वो भी मुझे मिल जाता है। तो निरामया हेल्थ इंश्योरेंस ऑल इन ऑल की बहुत अच्छा एक गवर्नमेंट की तरफ से दिया गया है।
So this is what the Niramaya health insurance that this parent is referring to offers. So as you can see, it covers non-surgical expenses and hospitalization involving that up to 15,000. It covers surgical expenses up to 40,000. It covers outpatient treatment, regular medical checkup, medicines, diagnostic tests up to 15,000. Dental procedures are covered, and transportation costs are also covered. And the therapies that she spoke about, that is covered to the extent of 20,000 rupees over here. So these are some of the documents that parents need when they are applying for the Niramaya health card. And there are some nodal agencies. In this case, I have listed the nodal agencies in Mumbai. But likewise, there are nodal agencies that are designated in different cities and different areas. The information about this is available on the website that you can see on your screens right now. So similarly, there are other parents who have put this card to use for other purposes. And here's another parent who talks about her experience.
नमस्ते, मेरा नाम मनीषा सतीश कांबळे है। मेरी बेटी का नाम शौनी सतीश कांबळे है। वो अभी 18 साल की है और शौनी को बचपन से ही ऑटिज्म है। इस साल मेरी बेटी ने 10वीं कक्षा की परीक्षा दी है। आज मैं आपको UDID के फ़ायदे बताने वाली हूँ जो मैंने 5 साल पहले निकाला था। ये एजुकेशन में शौनी को इसका बहुत ही फ़ायदा हुआ है। 10वीं कक्षा के में होने के कारण उसे राइटर मिला है, उसे एक्स्ट्रा टाइम मिला है, प्लस उसे टीचर्स का बहुत सारा सपोर्ट भी मिला है। इस तरह से एजुकेशन में UDID का फ़ायदा मुझे हुआ है। दूसरा फ़ायदा इनकम टैक्स में हुआ है। मेरे पति ने शौनी का UDID का सर्टिफिकेट इनकम टैक्स फॉर्म में लगाने के कारण उन्हें अच्छा डिडक्शन मिला है।
So I spoke about the education bit earlier. So these are some specific ways in which the UDID card and applying for a disability certificate can help. It can help you in getting admission in schools. It can help you with asking for classroom support.
once the disability certificate is presented. It can help you ask for concessions during exams. In higher classes, families can apply for scholarships, especially when children are appearing in classes between 9th to 12th grade. In higher educational institutions, there is a reservation of up to 5% of seats now. And also, it is helpful when one is thinking of the National Institute of Open Schooling to enroll in the NIOS board. The tax exemption that this particular parent was talking about, these are some of the details about the extent to which you can seek tax exemption. So similarly, I spoke about the other benefits, which includes also transportation. And these can help families in ways that are, that are things that you and I may perhaps even take for granted. And families often struggle a lot when they have to take public transport, when they have to travel from one place to another. So here's another parent who talks about how the UDID card has made her life much easier.
हेलो, मेरा नाम सलमा शेख है और मेरे बेटे का नाम जैद शेख है। अभी वो 8 साल का है, लेकिन वो जब 3 साल का था तब मैंने ध्यान दिया कि वो बहुत अजीब अजीब हरकतें करता था, किसी से बात नहीं करता था, बच्चों के साथ खेलता नहीं था, अकेले अकेले रहता था, कोई चीज़ें फेंक के मारता था। तो मैंने सोचा कि मैं डॉक्टर को बताऊँ। तो फिर मैं उम्मीद में जब गई तब मुझे पता चला कि जैद को ऑटिज़म है। और ऑटिज़म क्या है ये मुझे वहाँ जाने के बाद पता चला। फिर इसके बाद जो है मुझे UDID कार्ड के बारे में सोशल वर्कर से पता चला कि UDID क्या होता है। UDID कार्ड की वजह से हमें बहुत सारे फ़ायदे होते हैं बच्चों के। जैसे कि मैं मुंबई में किधर भी घूमना होता है तो मैं बस से ट्रैवल करती थी, जिस वजह से जैसे कि आपको पता है कि बस में बहुत ज़्यादा रश होता है तो सीट नहीं मिल पाती है। लेकिन जब मैंने UDID कार्ड बनाया तो जैद का पास फ्री हो गया था, जिसका कोई 1 रुपया भी चार्ज नहीं था। प्लस जैद के लिए स्पेशल एक सीट होती है जहाँ पे कि वो लोग को जब हम कार्ड बताते तो एक सीट मिल जाता है, स्पेशल एक सीट होता है वो मिल जाता है। और प्लस मैं जब गांव जाती तो मुझे टिकट कंफर्म मिलता है, 2 सीट जैद के लिए और मुझे कंफर्म मिलता है और उसमें कंसेशन भी मिल जाता है। जैसे कि 750 रुपये टिकट है तो मुझे 250 रुपये में 2 सीट मुझे मिल जाता है। तो UDID कार्ड का फ़ायदा मतलब जैसे कि मुझे बस के लिए भी और ट्रेन के लिए भी हुआ है। और
so these are some of the concessions that she has already spoken about when it comes to air travel. There is no concession in fee in the tariff, but you get other assistance in the form of getting a wheelchair or being able to avoid queues, or allowing for another person to escort a person with a disability. So there are also other benefits that one can avail of through the UDID card. So while the aids and appliances benefit is available or more pertinent to children with locomotor disability, CP, hearing and visual impairment, many times children with ASD may have some of these co-occurring conditions. And for them, then the cost of aids is substantially less. In fact, for families who earn 22,000 rupees per month or less, it can be completely free of cost. So if there is a child with autism and hearing impairment, the child can get access to hearing aids. And likewise, when it comes to children with visual impairment, the other technological aids that the children need for them to learn, they can get access to that. And likewise, children with cerebral palsy can get access to orthoses and other equipments that they need for mobility. So the important thing that we have found over the years is that what encourages parents to move forward in this journey despite their initial hesitation is firstly to see how do these rights and entitlements fit in with what they hope for their child. Without that, when this information is given in isolation, often parents don't see the value or the benefit of this and in fact think of it as too cumbersome for them to even go through the process. The second thing is for many parents, and all of the previous speakers have spoken about the multiple Indias that we all work with or deal with. For many of the parents, having basic documentation like the identity cards is something that they've not done for their children. And in fact, that proves to be a stumbling block. And because they haven't got that done, they don't go any further ahead in their journey to get the UDID card.
So when they get assistance in this, when some of this is made easier for them, then the next steps in the process also become easier. And last but not the least, once again, because we work with families who come from different socioeconomic backgrounds, literacy is a big challenge. So even though the government has made this process really streamlined and simple, the online filling of the form is still a daunting task. And sometimes providing them with a little assistance with processes like that can help them, can go a long way in fact, getting them the UDID card eventually. So these are two big ways in which anybody can support them. One is to provide them with the information about the card, its benefits, how the process of application works. And the second is to offer them real-time support for completing the form, uploading the documents, and getting the assessments done. In fact, many district hospitals in rural areas hold regular camps where this process, the families are supported end to end with this process, right from filling up the form to actually getting the assessments done and knowing what to track on the website on an ongoing basis until such time that they get the card. And in several places, the local district hospitals also collaborate with the NGOs working in the area to run such camps. So with that, I come to the end of my presentation and want to say that this is something that should be on our radar because government schemes and benefits can support the achievement of positive outcomes for children with disabilities and their families. And information and, like I said, a little guidance and assistance can lead to increased awareness, but also helping families go that extra mile in actually getting these cards for themselves and also putting them to use. Thank you so much for your patient listening, and I'm going to hand it back to Shweta again.
Thank you very much, Rupa ma'am, for the very informative talk. We do have a question in our chat box as well, whether the UDID is available in all the states. It's by Dr. Shivaprakashan.
Yes, it is. So the process for the UDID application, I'm just trying to stop sharing screen, please bear with me. The process for application would differ. In fact, in some of the states, the disability certificate and the UDID card process has not been seamlessly intertwined yet, where you still have to get a disability certificate separately and then apply for the UDID card. But in many of the states, both happen concurrently. And this seems like a process which is well on its way to also be applied all across the country uniformly pretty soon.
Right. Thank you very much. That brings us to the end of our webinar. Thank you everyone for your active participation till so late. I'd like to now hand over to Dr. Amit Saxena, sir, for the vote of thanks, please. Sir, you're muted.
Thank you, Dr. Shweta. And it was an amazing seminar. On behalf of IIT Navi Mumbai, I would like to thank all the speakers of national and international repute. Dr. Sameer Dalwai, Dr. Leena Deshpande Madam, Dr. Leena Srivastava Madam, Dr. Shambhavi Seth, and Dr. Rumpa Srinivasan, who took us through all the aspects of autism, right from the symptoms to evaluation, followed by the evidence-based interventions and the role of alternate treatments. And last but not the least, the government schemes to help the families with an autistic child. So I would like to thank all of you all for the wonderful talk. There was a lot of interaction also that shows us the beauty of the seminar which just happened today. I'd also like to thank Dr. Basant Khalatkar sir, President-elect CIT, and Dr. Shivaprakashan sir for their presence and encouragement. Dr. Shweta, congratulations for wonderfully moderating the session. The whole session was flawlessly conducted. And again, Dr. Vikram Patra for providing the audiovisual aids and the Zoom platform for the same. And the CME would not have been actually successful without the guidance of our Dr. Jitendra Gavane, Dr. Satish Shahane, and Dr. Mangai Sinha, and the whole of the team. And last but not the least, a big thank you to all the delegates for attending this seminar right till the end, asking questions, and thank you so much. Thank you.
Thank you, sir. Thank you a lot.
Thank you, everyone. It was really wonderful. A lot of information that we didn't know. Thank you to all the speakers. Thank you.
Thank you. Thank you.
Thank you, NMAP. Thank you, chapter.
Both Leena and all experts are always welcome on the Navi Mumbai dais. You can contact anytime.
Thank you, Dr.
Thank you
Satish.
for having us. Thank
Good
you.
night.
Good night.
Good night. Good night.
Good night, everybody. Thank you.
Bye.
आणि सॉरी तुम्हाला लेट झालं नीला मॅडम.
कोण?
झोपेची वेळ झाली तुमची.
माझी म्हणताय?
हा.
हो ना.